can also be done. So usually 30 minutes, so 30 to 45 minutes exercise 3 times a week. That is the recommended. So you engage in about 30 to 45 minutes of moderate exercise. These moderate exercises are usually the aerobics. So you engage in these aerobic exercise 3 times a week.
No, but they do practice them.
All right. Any other non-pharmacological ways?
It's an audience.
Hello.
Right.
No. But how is that before reason?
Not before. They are working, but they are not that working.
Hello.
Hi.
Hello.
Yeah. So any other non-pharmacological ways? So you've mentioned DASH diet, we've mentioned moderate exercises, cessation of smoking. In terms of the diabetes, what do you want to tell the patients? Non-pharmacological ways. Any ideas? So as much as possible, you also want them to modify their diet for glycemic control, because if your sugars are controlled, it also translates into improving the symptoms. So you want them to take in diets with low glycemic index. So instead of taking the simple sugars, you rather want to tell them to take the complex carbohydrates that will take time to digest and produce or increase their glycemic index. So you want them to take diets with low glycemic index. And you also want them to reduce the salt intake, sugar intake. Exercise is also there. So all these are ways of modifying the condition. Then for the dyslipidemia too, in terms of fat, you want them to take plant-based fats rather than animal-based fat. So we have bad fat, we have good fat. Usually the saturated fats, so the saturated ones and the trans fat, these are bad fats. They tend to accumulate within the vessels and cause atherosclerosis. So you want them to reduce the intake of saturated and trans fat. If they want to use oil for their food, it's better to go for the ones that are unsaturated, plant-based ones, sunflower oil, the olive oil. These ones are best for their cooking rather than taking the trans fat, margarines and all that. So all these are ways of counseling your patients non-pharmacologically. Now for pharmacological. So we've talked about how to modify smoking pharmacologically. Hypertension. You want to give them appropriate antihypertensives. So for peripheral artery disease, can you give them all antihypertensives, or there are certain antihypertensives you want to avoid? Any ideas? We're looking at the nature of the condition caused by atherosclerosis, vasospasms. Which antihypertensives do you want to avoid if someone has peripheral artery disease?
I think we'd avoid beta blockers.
Yeah, so it's best to avoid beta blockers, especially for those with established severe peripheral artery disease. So if they have severe, so if it's mild, you can use with caution. But if it's severe peripheral artery disease, you should avoid beta blockers. You know, beta blockers can cause peripheral vasoconstriction, especially the non-selective ones. It can cause peripheral vasoconstriction. So as much as possible, you want to avoid beta blockers. So the ones that are preferred, you want to give your ARBs, AC inhibitors, because they cause vasodilatation. Your arterial vasodilators like hydralazine, you can give them. All these can be used, but as much as possible, you want to avoid beta blockers. What about antidiabetics? Can you give all the anti-diabetics, or there are some that you want to avoid? Any ideas? So when you look at the complication of peripheral artery disease, we said that it starts with an occlusion. If that occlusion is not managed, it can lead to an ischemia. If that ischemia is not managed, it can lead to an infarct. And with time, if that is also not managed, it can lead to gangrenous manifestation. So the leg could become gangrenous because the occlusion is such that it's blocking almost all the lumen. That part is not getting blood. If it's not getting blood, that means oxygen and nutrients will also be deprived. In the area without oxygen, you know that anaerobes will thrive. So it could become infected, it could become dark. And when it becomes dark, we are looking at a gangrenous foot. And that gangrenous foot, we could have two types of gangrene. It could either be a dry gangrene or a wet gangrene. So the difference is that for a dry gangrene, usually the foot is dry and is dark and is not infected. So there's no infection, there's darkening of the foot and it's dry. But with wet gangrene, so the place is dark, you may have ulcers or some discharges around that, and you may have an infection. So it's usually an infected ulcer around the foot and it's dark. So that's the difference, wet gangrene and dry gangrene. So when it gets to that stage, the patient is at risk of amputation. So looking at the antidiabetics, there are certain antidiabetics when you have peripheral artery disease, it's always best to avoid because such antidiabetics can predispose you to amputation. So looking at the various antidiabetics, which ones do you think you should avoid if you have severe peripheral artery disease, which can predispose you to amputation?
SGLT2s.
Exactly. So the SGLT2 inhibitors. You know the SGLT2 inhibitors. Any examples?
There's canagliflozin, there's dapagliflozin, and there's empagliflozin.
Yeah, so we have dapagliflozin, empagliflozin, canagliflozin. We have a lot. but these are the common ones usually available. So with these agents, they realized that when compared to placebo, the risk of amputation was high in patients put on SGLT2 inhibitors, and the risk was highest with canagliflozin. So with canagliflozin, the risk is very, very high. So if the patient has risk of possible amputation, you should avoid canagliflozin. If possible, avoid SGLT2 inhibitors, but the risk is high with canagliflozin. So take note of that. But you can give the other antidiabetics, insulin, your metformin, and all that. They can be used in patients with peripheral artery disease. But for patients who have severe peripheral artery disease and possible risk for amputation, you avoid the SGLT2 inhibitors. Okay. So for dyslipidemia, pharmacologically, how do you modify? How do you modify dyslipidemia pharmacologically?
With statin.
Yeah, so you can give your lipid lowering agents like statins. So you know the statins, even though you may have a patient whose lipid profile is normal, but so far as they have an established peripheral vascular disease, which is an atherosclerotic condition, they should be on a statin. So far as they have developed an atherosclerotic condition, peripheral vascular disease, they should be on a statin. And the role of the statin here is for secondary prevention of cardiovascular events. So it has been postulated that once you have peripheral artery disease is more of a reflection of a systemic atherosclerosis that is ongoing. So that systemic atherosclerosis, we are having a manifestation in the legs, which is peripheral artery disease. But you may also be having atherosclerosis within the coronary vessels that can lead to MI, STEMI, and all that. Or you could also be having atherosclerosis in the cerebral vessels that can cause stroke. So once you have peripheral artery disease, that is an established cardiovascular event. So you want to prevent further cardiovascular events like the patient developing stroke, MI, and another event of peripheral vascular disease. So you put them on statins as secondary prophylaxis. So that's the role of the statin. So irrespective of the baseline lipid profile, whether it's high, normal, or low, you still have to put them on a statin once they develop peripheral artery disease. So that's how you modify the dyslipidemia. And usually you put them on high intensity statins. So high intensity statins. What is high intensity statin? When we say high intensity, what does it mean? Any ideas?
And I think they reduce the probability of getting cardiovascular events by more than 50%.
Okay, you have an idea, but is it reduction in cardiovascular events? So when we say high intensity, we are looking at the dose of the statin that reduces the LDL cholesterol. So it reduces the LDL cholesterol by 40%. So depending on the reference. So the British people talk about the dose of the statin that reduces LDL cholesterol by 40%, whilst the American references talk about the dose of the statin that reduces the LDL cholesterol by 50%. So that's the disparity in the definition for high intensity. The British references talk about 40% from LDL cholesterol reduction. Then Americans talk about 50% reduction in the baseline LDL cholesterol. So looking at atorvastatin, when you are using the British references, even the 20 milligram will qualify to be a high intensity statin because the 20 milligram reduces LDL cholesterol by 43%. So that is above 40%. So it qualifies to be high intensity. But if you are looking at the American reference, they quote 50%. So looking at that 20 milligram doesn't qualify to be high intensity. So their high intensity starts from 40 to 80. Whilst British references talk about 20 and above. But once the patient has peripheral vascular disease, patient has stroke, patient has any of the atherosclerotic condition, from the Sparkle trial, you use 80 milligram atorvastatin. So the preferred dose is 80 milligram atorvastatin. So they are all high intensity, but the preferred dose from the Sparkle trial is 80 milligram atorvastatin. Are you clear on that? Any questions, or you can move on?
Please, can you take that again?
So I'm saying that the statin that reduces LDL cholesterol by 40% is high intensity according to the British references. And the American reference talk about the dose of the statin that reduces LDL cholesterol by 50%. So that's the disparity in the definition. So if you look at 20 milligram atorvastatin, reduces the LDL cholesterol by 43%. So that qualifies to be high intensity according to the British references. But 20 doesn't qualify to be high intensity per American. So theirs start from 40 to 80, whilst American talk about 20 to 80. But if the patient has an established cardiovascular event, like peripheral vascular disease, MI, stroke, the preferred dose is 80 milligram atorvastatin. And this was from the dose they used in the trial, the Sparkle trial. That is why the established dose is 80. Unless the patient is having side effects, then you may want to reduce the dose to 40. But the preferred dose is 80. Is that clear?
Yes, please.
Any questions, or we can move on? Okay, so that's how you modify the risk factors, non-pharmacologically, pharmacologically. And for the vasospasms, we say this is triggered by stress. It's also triggered by a cold temperature. So usually when these triggers are removed, the patient should get some relief. But aside modifying the triggers or the risk factors, the other thing is you can put them on calcium channel blockers. So if the cause is a vasospasm, so Raynaud disease. So for Raynaud disease, which is caused by vasospasm, and this is triggered by cold and stress, you want to manage these risk factors, and you also want to give the patient calcium channel blockers. And we are giving them calcium channel blockers because these agents would inhibit calcium influx into the vessels, causing vasodilatation. So it helps with perfusion to the extremities. So calcium channel blockers can be used but you always have to avoid beta blockers in Raynaud disease because they can worsen by causing peripheral vasoconstriction. Can we move on? All right. Now let's talk about intermittent claudication. So one of the main things that will bring patients to the facility is the intermittent claudication. And they will start narrating to engineering gate or faculty to tech junction without feeling any pain. But now, when they walk from faculty to, say, a great junction, they start feeling pain in their legs. So, in terms of walking distance, they have
Yeah, please, I don't know if I'm the only one, but your line is breaking.
a reduced walking distance before claudication.
Oh,
One Hello.
Hello.
Yeah, can you hear me?
Yes, please.
Yes, please.
Okay. So we're talking about the intermittent claudication. So I said for intermittent claudication, basically the patient would start feeling pain during exertion of the muscles. But once the patient rests, the pain is relieved. So we want to give agents that will help relieve the pain during these episodes of intermittent claudication. So any agent that you can think of that we can use for intermittent claudication. Any agent? All right. So we have certain drugs that are used for intermittent claudication. So typically your usual pain medications may not be sufficient in patients with intermittent claudication. So there are certain agents. Looking at the nature of the condition, where there's an occlusion, there's reduced perfusion to the peripheries, you may need agents that sort of help relieve the occlusion and also help improve perfusion to the extremities. So one of them is called cilostazol. So there's a drug called cilostazol. We also have pentoxiflin. Pentoxiflin. Then we also have naftidural oxalate. So I've typed them in the chat box. So we have cilostazol, pentoxiflin, and naftidural oxalate. So these are the agents that are used for intermittent claudication. So we take them one after the other and talk about them. So we start with cilostazol. So basically, cilostazol, what it does is a phosphodiesterase type 3 inhibitor. So you know phosphodiesterase inhibitors. There are a lot of phosphodiesterase enzymes. The common ones you know are the phosphodiesterase type 5 inhibitors that are used as medication for erectile dysfunction, so sildenafil, tadalafil, and the rest. These are phosphodiesterase type 5 inhibitors. We also have phosphodiesterase type 3 inhibitors. An example is cilostazol. So basically what cilostazol does is it inhibits phosphodiesterase type 3. Once this enzyme is inhibited, this enzyme endogenously is supposed to break down cyclic AMP. So once you inhibit phosphodiesterase type 3, what it means is that cyclic AMP would accumulate. And once cyclic AMP accumulates, cyclic AMP is very beneficial in peripheral artery disease because it has vasodilatory effect and it also helps prevent platelet aggregation. So for this reason, it gives cilostazol that would inhibit phosphodiesterase type 3, allowing cyclic AMP to accumulate. Once cyclic AMP accumulates, there's vasodilatation that can improve perfusion to the extremities. You could also have prevention of platelet aggregation that will also reduce the occlusion in the vessels. So this is the main reason why we give cilostazol. So take note, it has antiplatelet effect, it has vasodilatory effect as well. Okay. So what's the dosing? So when you are giving for patients with peripheral artery disease to manage intermittent claudication, what dose do you give? Any ideas? All right, so the dose is 100 milligram BD. So you give 100 milligram BD. And usually you advise the patient that in terms of the benefits of taking the drug, they'll start seeing benefits usually after 3 months. So the full benefits of the drug will be seen after 3 months. We have to psych the patient so that when they take the drug for 1 week, 2 weeks, they don't start complaining that the drug is not working, they are not having any benefit. You have to allow them, or you have to counsel them enough to know that the drug, in terms of the maximal benefits, will be seen after 3 months. So they shouldn't expect any miracle after 2 weeks or 1 week of taking the drug. And in terms of counseling too, you want them to take it 30 minutes before meals or 2 hours after meals. So the drug should be taken 30 minutes before meals or 2 hours after meals. And this is because food increases the absorption, it markedly increases the absorption and also the peak concentration. So if you have a lot of the drug being absorbed quickly, the peak concentration can increase suddenly and cause toxicity and side effects. So because of that, you want to take it 30 minutes before meals or 2 hours after meals to prevent that side effects of the drug. So that's the counseling in terms of food administration. And the other thing I want you to note about cilostazol is it's contraindicated in patients with all severity of heart failure. So if the patient has heart failure, irrespective of if it's New York Association class 1 or class 2 or class 4, it's contraindicated. And this is because there are other agents that are phosphodiesterase type 3 inhibitors. These agents were compared with placebo. And once they compared with placebo in patients with heart failure, they realized that patients who were put on phosphodiesterase tend to have higher cardiovascular mortality compared to patients who were on placebo. But because of that, patients taking cilostazol or any phosphodiesterase type 3 inhibitors, once they have heart failure, they should avoid. So once you have heart failure, irrespective of the severity, because of the increased cardiovascular mortality from patients taking phosphodiesterase type 3 inhibitors, cilostazol should not be given. So let's take note of that. Any questions? Okay. So usually, in terms of yeah.
I have a question. You stated that the benefit starts after 3 months or from 3 months onwards. So in the meantime, with the person still having
I
the
can't really hear.
Pardon?
I can't really hear you. So come
I was
again.
saying that I was told the patient the effect of this medication, the benefit starting from 3 months onwards. So in the meantime, what would the patient have to be put on to manage the intermittent claudication?
So if we talk about the benefits, we are looking at the maximal benefits. So the patient may have some relief, but the maximal benefit of the drug will be seen after 3 months. Do you get it? So whilst they are on it, they may see some benefit, but in terms of maximal benefit, it's after 3 months.
Okay, thank you very much.
You're welcome. Any other questions? Okay. The next drug is pentoxifylline. So pentoxifylline. So looking at the name, pentoxifylline belongs to the methylxanthine class. And you know the methylxanthines. Theophylline, caffeine, all these are methylxanthines. So pentoxifylline belongs to the methylxanthines. So what pentoxifylline does is pentoxifylline modifies the rheology of blood. So we usually call it a rheologic modifier. So rheologic modifier. So what this means is that when you look at the meaning for rheology, rheology is basically the viscosity of flow. So if you are saying this is a rheologic modifier, what it means is it's going to reduce the viscosity of blood and allow blood to flow easily. So the issue with peripheral artery disease is there's sort of an occlusion leading to an ischemia. So we need something to help improve blood flow to the extremities. So pentoxifylline acts as a rheologic modifier. And this means that it's going to reduce the viscosity of blood and improve the flow of blood. Aside that, it also has antiplatelet properties. It prevents platelet aggregation. So that is also one of the benefits of pentoxifylline. So aside reducing viscosity of blood, it also prevents platelet aggregation. And the other thing is it also improves RBC deformability. So what this means is when you look at the red blood cells are biconcave. And this nature allows them to do that by changing the shape. So they are able to change their shape and meander through smaller vessels. So what pentoxifylline does is it improves RBC deformability, allowing these RBCs to meander through smaller vessels and get blood to the areas that are ischemic. It also improves RBC deformability, allowing blood to flow through smaller vessels. So all these are benefits of pentoxifylline.
Hello, Doc.
Hello.
Doc, please, while I was breaking up, can you please take the pentoxifylline again?
Okay, so for pentoxifylline, I was saying it's a rheologic modifier. So what this means is that it's going to reduce the viscosity of blood and allow blood to flow easily. So the issue with peripheral artery disease, there's an occlusion, there's something preventing blood from flowing easily. So pentoxifylline reduces viscosity of blood and allows blood to flow easily. The other thing is it has antiplatelet effects. So it prevents platelet aggregation. And I also mentioned that it improves RBC deformability. And what this means is that for smaller vessels, the RBCs have to undergo some deformation. So they have to change their shape to meander through smaller vessels. And giving pentoxifylline can help improve the deformability so that RBCs can go through smaller vessels and get to the ischemic areas. Is it clear?
Yes, please. Thank you.
Okay.
What did you say about the RBC?
So I said RBC deformability, red blood cell deformability. So pentoxiflin can improve RBC deformability. So it will improve the ability of RBCs to change their shape and meander through smaller vessels. So just like hydroxyurea, for sickle cell patients, the RBCs are sickle, they are rigid, they are not able to move through smaller vessels. So one of the benefits of hydroxyurea is to improve RBC deformability so that these rigid sickled RBCs can meander through smaller vessels and prevents the vessel occlusive crisis. So the same reason pentoxiflin acts to improve RBC deformability, improving blood flow to extremities. All right. So let's move on. So just like cilostazol, pentoxiflin can also be given for intermittent claudication. Just that in terms of efficacy, cilostazol is more efficacious compared to pentoxiflin. So looking at the three agents, naftidural oxalate, cilostazol, and pentoxiflin, the most effective one is the naftidural oxalate, followed by cilostazol, and pentoxiflin is the least effective. So some references may not recommend pentoxiflin, but the most effective one is naftidural oxalate, which is not readily available in our setting. The ones that are readily available is cilostazol and pentoxiflin. Okay. So for pentoxiflin, usually the dose is 400 milligram TDS. So usually do 400 milligram TDS. And the other thing is for pentoxiflin, if the patient has allergies to methylxanthine products, you should also avoid pentoxiflin. So if they have allergies to maybe theophylline, caffeine, they may develop a cross sensitivity to pentoxiflin. So you want to avoid in patients with hypersensitivity to the methylxanthines. Then the other thing is the naftidural oxalate. So for naftidural oxalate, we said is the most effective agent for intermittent claudication. And basically, this agent
Doctor.
inhibitor. So it inhibits 5-HT2
Hello,
receptor.
doctor.
Yeah.
Doctor, please, someone is asking a question in the chat box. Can you please answer that question for us?
Let me finish with naftidural.
Okay, please. Thank you.
So naftidural oxalate, we said it's a 5-HT2 receptor blocker. So when we say 5-HT2, 5-HT2 is one of the serotonin receptors. The 5-HT means 5-hydroxytryptamine. That is basically serotonin. So you have a lot of serotonin receptors, 5-HT3, the ondansetron and all that. These are anti-emetic. You have 5-HT2, which is a serotonin receptor as well. So, naftidural oxalate inhibits 5-HT2 receptor. And after inhibiting, serotonin is a vasoconstrictor. So if you are inhibiting 5-HT2 receptor, in effect, you are sort of causing some vasodilatation. So that is one of the reasons why we use naftidural oxalate. The other reason is naftidural oxalate also improve ATP generation. And this it does by improving glucose uptake in the tissues. So it improves glucose uptake in the tissues that allows for ATP to be generated. So we said for intermittent claudication, the pain comes in during exertion. So when they are at rest, they may not feel the pain because the muscles do not need a lot of energy at that time. But the moment they exert themselves, they walk, they run, the muscles tend to need a lot of energy. So because of that, there is an oxygen deficient that causes adenosine to be released. ATP is deficient in that area. What happens is when you give 5-HT2 receptor blocker, naftidural oxalate, it's able to improve glucose uptake in the tissues and allow for more ATP to be generated. Once you have a lot of ATP for the muscles, the pain reduces. So that is how naftidural oxalate works. And you said is the most effective. So they
Sir,
compared
please, I beg,
naftidural
please,
with
can you go
glucose.
back with the naftidural? I'm sorry, I couldn't hear.
So all that I've been saying is it's a 5-HT2 receptor blocker. So it blocks the serotonin receptor and prevents serotonin from binding to its receptor. We said serotonin is a vasoconstrictor. So if you are preventing serotonin from binding to 5-HT2, in effect, you are causing vasodilatation. And the other reason is the naftidural oxalate improves glucose uptake in the tissues. So when glucose uptake in the tissues is improved, you have a lot of ATP being generated from glucose utilization. And what this means is that the muscles there will be getting a lot of energy during exertion. The pain in intermittent claudication occurs during exertion. It is relieved during rest. This is because once you exert the muscles would need more energy. So they need more ATP. But this is a situation where there's an occlusion, blood is not getting there. So oxygen and nutrients are not getting there for ATP to be generated. So what essentially naftidural oxalate is doing is improving ATP generation in the tissues. And that's helping with intermittent claudication. So he said naftidural oxalate is the most effective agent of all the agents. So cilostazol follows, then pentoxiflin is the least effective. So in terms of efficacy, they compared them based on pain-free walking distance and the maximal walking distance. So back to the scenario I was using. So if initially the patient was able to walk from, say, faculty to Tech Junction, and now they walk from faculty to Agric, and they are feeling the pain. Once you put them on these agents, what they do is they would increase the pain-free walking distance. So they can improve the patient walking distance by allowing the patient to walk from, say, faculty to botanical gardens without feeling the pain, or from faculty to Tech Junction without feeling the pain. So in effect, they've increased your pain-free walking distance. and they also increase your maximal walking distance. So what this also means is that so the maximum distance you can cover before you start feeling the pain. So initially, you could walk from Faculty to Tech Junction without feeling the pain. That was your maximal walking distance. The pain will only start when you get to Tech Junction. That's your maximal walking distance. So in terms of your maximum increase, so that is how they compare the three agents. And of all the three agents, naftidural oxalate had the maximal walking distance and pain-free walking distance, followed by cilostazol, and pentoxiflin was the least. That is why we are saying it's the most effective. And the dosing is 100 to 200 milligram TDS. So for naftidural oxalate, 100 to 200 milligram TDS. Looking at the drug, naftidural oxalate, what would you be concerned about? Which side effects would you be concerned about looking at the name of the drug?
Okay, oxalate crystal formation. Calcium oxalate crystal formation.
Kidney
Exactly. So the patient would have kidney stones, nephrolithiasis. So the patient could have nephrolithiasis, and this is basically kidney stones. So there are a lot of kidney stones. We have calcium oxalate, we have struvite, we have a lot of them. So all these are stones that can be formed from either intake or based on certain lifestyle. So looking at the drug is naftidural oxalate. So the oxalate crystals could accumulate in the body and form kidney stones. When they combine with calcium, they can form calcium oxalate crystals, and this can block the kidneys. The patient could develop kidney stones from naftidural oxalate. So if the patient has a prior history of kidney stones, you have to avoid naftidural oxalate. So that's the caution in there. So you avoid naftidural oxalate if they have history of kidney stones. The same way you also have to avoid cilostazol if the patient has heart failure because of the increased cardiovascular mortality. Okay. Any questions?
Sir, please repeat the very last statements you made.
Yeah, so I was talking about for patients with history of kidney stones. So if the patient has history of kidney stones, you have to avoid the hello, hello,
Hello, sir.
hello.
Hello.
Yeah. Hello.
Hi.
Yeah, so I think we were talking about the naphthalene dural oxalate. So I said for patients who have history of kidney stones, you want to avoid the naphthalene dural oxalate. Then for patients who have history of heart failure, you also want to avoid cilostazol. Any questions? Okay. So for patients with intermittent claudication, I said in our part, in our setting here, is the cilostazol and the pentoxiflin that is readily available. So we tend to use more of the cilostazol since it's more effective than pentoxiflin. So that's what we use in our setting more often. Then I saw some questions in the chat box. So someone was asking whether we can use polycosanol in the management of intermittent claudication. So currently there is no evidence for use of polycosanol in the management of intermittent claudication. So it's the three agents I've talked about: pentoxiflin, the cilostazol, and the naphthalene dural oxalate. These are the three that are used in intermittent claudication. Polycosanol finds use in patients with dyslipidemia. So that's where we use polycosanol, but not intermittent claudication. And there's another question about its using pentoxiflin using sickle cell disease patients. It's also not indicated for sickle cell disease patients. It's only used in intermittent claudication, even though it has ability to improve RBC deformability. But sickle cell patients, you are looking beyond that. We are actually looking at modifying the fetal hemoglobin, increasing fetal hemoglobin with hydroxyurea and all that. And there are other agents that are coming up to modify the disease course. There are even gene therapy now that can sort of correct the mutation. So all these are coming up. So pentoxiflin doesn't have any use in sickle cell. Any other questions before we continue? Okay. So the next thing we'll be talking about, so aside the intermittent claudication, since it's an atherosclerotic condition, you want to put the patient on antiplatelets like aspirin, clopidogrel to prevent platelet aggregation and also secondary prophylaxis of cardiovascular events. You can also do the statins as well. Aside that, for patients with peripheral venous disease, so the management for patients with peripheral venous disease, we are also looking at the causes. So you manage the causes of the peripheral venous disease. For peripheral venous disease, we said there could be issue with an occlusion in the veins, there could be distended veins, there could be issues with the valves and all that. So that is what you manage. So if the issue is an occlusion within the veins like DVT, then we are looking at using pharmacological management. So you could use anticoagulants. So your heparins, your DUACs, the new agents that are coming up, rivaroxaban, apixaban, and all that, they can be used in DVT. So if the cause is DVT, that's where you use anticoagulants. So take note, arterial. So if the issue is with the arteries, you use antiplatelets. But if the issue is occlusion within the veins, you use anticoagulants. Why is that so? Why are we using antiplatelets when we have peripheral artery disease, but we use anticoagulant when you have peripheral venous disease? Any ideas? So if you look at the nature of the arteries are said to be fast flowing vessels. So what it means is that blood moves very fast within the arteries, whilst the veins, blood moves very slowly because it's moving against gravity. It has to do it with the help of these valves. So in terms of the nature of blood flow, you realize that arteries, blood flow is very fast, vein blood flow is very slow. Then in terms of the platelets, when you look at the arteries usually form clots that are platelet rich. So when there's an injury to the arteries, the platelets are getting to the site and they could form a clot. So the clot that is formed within the arteries are usually platelet rich. And this is what we call the white thrombus. So the thrombus that is formed in arteries are platelet rich and they are called white thrombus. If you look at the veins, we said blood flow is very slow. So based on the next topic we'll do will be DVT and P. So if you look at Virchow's triad, we are looking at endothelial injury, hypercoagulability, and blood stasis. So whenever blood flow is slow, there could be stasis. When there is stasis, the nature of clot that is formed will be high in clotting factors. So in terms of clot that is formed in the veins, it's high in clotting factors. So it's fibrin rich. So you have a lot of fibrin in clots that are formed within the veins. So looking at the agents that are used for arteries, because it's platelet rich, we tend to use antiplatelets. Like it's veins, because it's clotting factor rich or fibrin rich, we tend to use anticoagulants because these can target the clotting factors in the various pathways. So that is the difference. So if it's DVT, we use anticoagulants. If the patient has varicose veins, so for varicose veins, what do we use for varicose veins? Any non-pharmacological management for varicose veins?
Stockings.
Yeah, you can use stockings. So what type of stockings? We have different types of stockings. We have TED stockings and we have compression stockings. What's the difference between TED stockings and compression stockings? So before we talk about the difference, the TED, what does it stand for? What does the TED stand for?
Please, thromboembolic deterrent.
Yeah, so TED stands for thromboembolic deterrent. So thromboembolic deterrent stockings. Then we have compression stockings. So looking at the two, what are the difference? Which one would you use for DVT prevention? If you want to prevent DVT, which one would you use? Oh, so looking at the name, if you want to prevent DVT, TED stockings or compression stockings?
Third stockings.
TED stockings,
Compression.
because thromboembolic deterrent. So it's going to prevent thromboembolic events like DVT and P. So we use TED stockings in DVT and P. We use TED stockings in DVT prevention. But we don't use compression stockings in DVT prevention. Compression stockings are used in patients with varicose veins, chronic venous insufficiency, lymphedema, where you need a higher compression. So we tend to use compression stockings in these conditions. But TED stockings is used for DVT prevention. Aside that, any other difference between TED stockings and compression stockings? So looking at TED stockings, compression stockings, which one do you think we will use for immobile patients? So if a patient is immobile, do you think we should use TED stockings or compression?
I think TED stockings.
TED stockings, exactly. So TED stockings is used to prevent DVT. So if the patient is immobile, the risk for DVT is high. So we use it in immobile patients. But compression stockings are usually used in ambulatory patients. So patients who can walk around, they are mobile. Those are the patients who wear compression stockings. So usually, even some of the nurses at the ward, you see them wear some particular socks to give some compression. So that can be worn by ambulatory patients. But TED stockings only for immobile patients. Then in terms of the pressure differences, we could have differences. So TED stockings usually delivers 8 to 18 millimeters mercury of pressure gradient. So the pressure gradient is usually 8 to 18 millimeters mercury. So 8 to 18 millimeters mercury for TED stockings. But the compression stockings require higher pressure. So usually 20 to 30. Others can go even to 40. So 20 to 30 or 20 to 40 millimeters mercury. So compression stockings usually require a higher pressure. So if the patient has varicose veins or chronic venous insufficiency, they can use compression stockings. Then the other thing is for patients who have chronic venous insufficiency, they could also benefit from phlebotropics. So there are certain drugs we call phlebotropics. And these phlebotropics, basically what they do is they increase venous return. So the veins are supposed to send blood back to the heart. So these phlebotropics are able to cause some constriction in the veins, and this increases venous return back to the heart. So example is diosmin. So if you've heard of Phlebodia or Daflon, so the ingredient in Phlebodia is diosmin. Daflon too contains diosmin. And these are what we call phlebotonics or phlebotropics. So they increase the venous return by causing vasoconstriction in the veins. So these can also be used for patients with chronic venous insufficiency. So essentially, for peripheral venous disease, depending on the cause, you manage appropriately, because how you manage DVT is different from how you manage varicose veins or chronic venous insufficiency. So you manage the underlying cause. And for peripheral venous disease, there's no place for the use of cilostazol, naltrexone, or the pentoxifylline. They are only used for peripheral artery disease. So they are not used for peripheral venous disease. Any questions?
Sir, please can you repeat the mechanism of action of the phlebotropic?
So I said phlebotropics, they increase venous return back to the heart by causing vasoconstriction in the veins. So they constrict the veins. By constricting the veins, they are helping push blood back to the heart. So they reduce the pooling of blood in the legs. So that is how these agents act. Any other questions? All right, so that is how you manage peripheral venous disease. The other thing I want to talk about is for surgical interventions. It's not really one of the main managements that we used. Most of the management will be around medical management. So we want to use drugs. We want to modify the risk factors and all that. But if it gets to the critical stage, then the patient may need some surgical intervention. So for peripheral artery disease, they can at times put a stent in the arteries to open up the arteries and allow blood to get to the extremities. They can also do a bypass. So if the occlusion is very severe, they can bypass that occlusion through collateral vessels so that blood can get to the extremities. So they can do peripheral artery bypass, or they can do stenting, or they can also do removal of the clot or occlusion. So they can do end endarterectomy to remove the occlusion in there. So all these are surgical interventions, but these are not usually done. So the focus is more on the medical management. Okay. If there are no questions, I've sent you some questions on the topic. So let's quickly go through that, and that'll be the end. So someone can share the screen. So someone can share their screen so that we'll go through the questions. Is someone sharing their screen?
Doc, please, it seems only the host can share the screen.
Okay. So who is the host? Abena Bona. Abena Bona, you can share your screen, or if you can't share, you can allow for other people to share.
Okay, I'll allow because I can't share it.
Abena, have you allowed someone to share?
I'm not seeing anyone who wants to.
No, I think you can change the settings so that anyone can share.
Okay. So I'm coming.
Okay, so who is reading for us?
Okay, so trial questions on peripheral vascular disease. Peripheral vascular disease affects all these vessels except iliac artery, femoral artery, middle cerebral artery, and popliteal artery.
Okay, so the exception is which of them?
The middle artery.
Yeah, so the middle cerebral artery. So we said peripheral arteries are basically the vessels supplying all parts of the body except the heart and the brain. Middle cerebral artery supplies the brain. So the others supply the periphery.
Number 2,
Okay.
peripheral vascular disease affects only the arteries, true or false?
Okay. True or false
False.
statement?
False.
False.
Yeah, so it's false. It can also affect the veins. Okay.
Number 3. Most common cause of peripheral artery disease: smoking, atherosclerosis, diabetes, dyslipidemia.
Atherosclerosis.
Atherosclerosis.
Yeah, so atherosclerosis.
Number 4. The following are the risks for peripheral venous disease except pregnancy, cold, standing for long, obesity.
Okay, so what are you going for?
Cold.
Cold.
Yeah, so cold. Cold is a risk factor for peripheral artery disease, not peripheral venous.
Number 5. All these are possible causes of peripheral venous disease except Raynaud disease, chronic venous insufficiency, varicose veins, deep vein thrombosis.
Yeah, so Raynaud disease causes peripheral venous.
Number 6. Dependent position worsens pain in peripheral artery
Not
disease.
causes peripheral artery. So the others causes peripheral venous.
Number 6. Dependent position worsens pain in peripheral artery disease. True or false?
False.
False.
Yeah, so it's a false statement.
Number 7. Which counseling would be prioritized in patients with Weger's disease? Low-fat diet, blood glucose control, smoking cessation, blood pressure control.
Smoking
Smoking.
cessation.
Yeah, so smoking cessation. We said Buerger's disease usually affects both arteries and the veins. And we said the other name is thromboangiitis obliterans, and usually associated with patients with significant smoking history. So you want to advise them to cease smoking.
Number 8. All the following are true about Raynaud disease except triggered by cold or stress, occurs due to vasospasms of peripheral veins, affect the toes, fingers, and sometimes ears and nose, treated with calcium channel blockers.
Occurs due to vasospasm of peripheral veins.
Affect the toes, fingers, and sometimes ears and nose.
Okay, so I'm hearing two answers. Some are going for B, some are going for C. So which is which? Is it B or C?
B.
Or any
B.
other answer there?
B.
Why B?
Because it's peripheral arteries, not peripheral veins.
So you have to be very careful. So Raynaud phenomenon, though is caused by vasospasm, triggered by cold and stress. By the
Sir, please, we can hear you.
veins. So take note. Yeah, so the answer is B. It causes vasospasms of the peripheral arteries, not the veins.
Number 9. Your patient reports experiencing dull and achy sensations in lower extremities. You noted that the lower extremities have edema and brownish pigmentation. Ulcers are present and the extremities feel warm to touch. To help alleviate the patient's symptoms, it's recommended to position the lower extremities in the A. Dependent position, horizontal position, elevated position above the heart level, knee flex position.
Elevated position above the heart.
Okay, so looking at the description there, it's pointing to peripheral venous disease. So there's blood pooling in the lower extremities. So we rather recommend that the patient elevates the legs. That would allow blood to move back to the heart. So that is the counseling you give.
Number 10, a patient has an arterial ulcer on the lower extremity. Which of the following is not a risk factor for the patient's peripheral artery disease? Varicose veins, smoking, high cholesterol, diabetes mellitus, uncontrolled hypertension.
Varicose.
Varicose veins.
Okay, so what are you going for?
Varicose vein.
Yeah, so varicose veins is not a risk factor. So all of them are risk factors for atherosclerosis.
Number 11, peripheral artery disease leads to a decrease in rich oxygenated blood being delivered to the lower extremities, which leads to blood pooling, ischemia, and necrosis of skin tissue. True or false?
False. False. False.
Why false? So peripheral artery disease doesn't cause blood pooling. That is caused by peripheral venous. So the answer is false. Let's move on.
Peripheral venous disease can occur due to narrowing of the valves in the vein of the lower extremities. True or false?
True.
Okay, so what are you going for?
True.
Okay, is everyone going for true? Are you all going for true?
Now I'll go for false. Yeah.
Why false?
Cells become overstretched.
False.
Exactly. So for peripheral venous disease, it's not because of the narrowing of the valves, but rather overstretching of the valves. So it's not narrowing of the valves, but rather overstretching of the valves. So that's a false statement.
13. You are assessing a patient's health history for peripheral vascular disease. What signs and symptoms reported by the patient would indicate the patient may be experiencing peripheral venous disease? I often wake up at night with leg pain and have to dangle my leg out of the bed to ease the pain. If I stand or sit too long, my legs start to feel heavy and achy. It hurts to elevate my legs. Sometimes, when I'm walking, my legs start to cramp and tangle to the point where I can't walk until the pain goes away.
If I stand or sit too long, my legs start to feel heavy and achy.
Exactly. So for peripheral venous disease, the moment you stand for long or you sit for long, you have blood pooling at the extremities. So your leg will start feeling heavy and achy. Unlike peripheral artery, that the pain will come on exertion, you rest and it's relieved. You may have to dangle your legs and all that. So that is for peripheral artery. But peripheral venous, blood pooling occurs when you stand or sit for long.
Okay. 14. Your
Hello, Doc.
patient. Okay.
Hello.
Please, what about option C and then D?
So C is it has to elevate my leg. So that becomes peripheral artery disease. Peripheral artery, blood is not getting to the extremities. So when you elevate it, blood would reduce to the extremities. So the best is to dangle the legs, that is in the dependent position below the heart level, to improve perfusion to the extremities. But for peripheral venous, the pain is rather relieved when you elevate your legs because blood would easily return back to the heart. So that is relieved when the legs are elevated. And if the patient starts to feel pain when they walk for a long time, then that's peripheral artery. So the one that qualifies peripheral venous is the sitting or standing for long. Okay, let's move on.
14. Your patient has severe peripheral artery disease. When the lower extremities are elevated, you would expect them to dash. And when they are in the dependent position, you would expect them to appear dash. Cyanotic and rubor. Rubor, pallor. Cyanotic, pallor. Pallor, rubor.
Okay, so what are we going for?
Pallor rubor.
Yeah, pallor rubor. For peripheral artery disease, when they elevate the legs, blood is not getting to the extremities. So the legs will become pale because they have reduced perfusion there. But the moment they dangle their legs in the dependent position, it improves perfusion. So blood gets there and the place becomes reddish. So that's rubor. Mhm.
Okay. 15. A patient has severe peripheral venous disease. All the following are important information to be provided to the patient about how to alleviate signs and symptoms associated with the disease, except elevate the lower extremities below your heart frequently, application of compression stocking, limit long periods of standing and sitting, avoid crossing of legs.
Elevate the lower extremities below heart level frequently.
What are you going for? I'm hearing A. And I'm also hearing C. Is everyone going for A?
Yes, please.
But I think peripheral venous, it's better to elevate the leg.
It's below heart level.
So you have to be very careful. You have to elevate your leg up heart level. Is it possible to elevate it below heart level? It's not possible. It's rather above heart level. Okay, let's move on.
Your patient has severe peripheral venous disease. During the head-to-toe assessment, you would expect to find poor skin characteristics of the lower extremities: thick and tough skin, thin and scaly skin, hairless skin, brittle nails.
Thick and
Thick
tough
and
skin.
tough skin.
Yeah, so thick and tough skin.
A patient has an ulcer on the medial malleolus. The ulcer is shallow with irregular edges. The wound base is red. Wound drainage is also present. What type of ulcer is this based on the scenario's description? Venous ulcer, arterial ulcer, diabetic ulcer, Kerlin ulcer.
Venous ulcer.
So,
Yeah, so venous. We said that's usually seen in the medial part of the leg. So the medial malleolus. You could also have irregular edges in the ulcer, and the ulcer base is shallow with a lot of drainage. Then it may appear reddish. So that is a venous ulcer. The arterial ulcers are usually at the extremities with very little drainage, and the ulcers are usually deep. Okay.
You are providing discharge teaching to a patient with peripheral artery disease. Which statement by the patient requires you to re-educate the patient? It is important I quit smoking. To prevent my feet and legs from getting too cold at night, I will use a heating pad. A walking program would be beneficial in treatment of my PAD. I will avoid wearing tight socks or shoes.
A walking program. C.
So what are you going for?
C.
Okay, I'm hearing C. Any other answer?
I'll go for B.
Okay. Any reasons?
I really don't see how, with the three other options, I see that they can be beneficial in PAD. But with the heating pad, I'm wondering how it would be beneficial to the patient. That's why I'm choosing that as the odd one.
Okay. So that's true. So as part of the counseling, you want them to quit smoking. You also want to advise them to exercise. So a walking program is advised, usually a supervised exercise. And you also want them to avoid wearing tight socks and shoes. Already there's reduced perfusion there. The issue is that these patients, when it progresses, the condition progresses, they may have reduced pulse, reduced sensation. So if the patient starts telling you that to avoid having cold feet and legs, they would use a heating pad. This is not advisable because if they've lost sensation there and they are stepping on heating pads and all that, they may develop ulcers there without knowing because they are not feeling the heat. And this is not advised in someone with peripheral artery disease where they've lost perfusion in terms of sensation and all that have been reduced. You want them to avoid using heating pads because they can, just like diabetic foot ulcers, the neuropathic ones, it affects the nerves. So without knowing, you can step on something and there will be ulcers without even getting to know that there are actually ulcers there. So you want to advise them to avoid heating pads. Let's move on.
Match the following to the keys below: Leriche syndrome, Raynaud disease, Buerger's syndrome, dry gangrene, wet gangrene. So 19. commonly associated with chronic smokers?
Buerger's syndrome.
Buerger's syndrome.
Yeah, so that's
Buerger's
Buerger's.
syndrome.
Yeah.
Exacerbated by cold and stress.
Renal disease.
Usually associated with erectile dysfunction.
Larish syndrome.
Yeah, so Larish syndrome is one of the peripheral artery disease. So usually, depending on where you have the occlusion, it affects the distant areas. So if you have the occlusion around the aortoiliac, so from the aorta you go to the iliac, then you go to the lower vessels, the femoral, the popliteal, and you go downwards to the tibial. So if it's around the aorta to the iliac is around the pelvic region. So for patients who have occlusion within the aortoiliac area, it affects blood flow to the pelvic region. And you know the pelvic region is where you have your genital. So before you can get an erection, you need blood to fill the pineal gland, and that helps with erection. So this is an occlusion blocking perfusion. So it can affect the patient. The patient may develop erectile dysfunction. So Larish syndrome is actually a triad of symptoms. So the patient will be complaining of intermittent claudications, usually around the thigh, because the occlusion is around the iliac region, the pelvic. It affects perfusion to the thigh area. So the patient will complain of pain around the thigh. The patient may also have impotence. And when you check for femoral pulses, they would usually have absent femoral pulses. That shows the gravity of reduced perfusion. So that can occur in patients with aortoiliac occlusion.
Presents with infected ulcers and necrotic tissues.
Wet gangrene.
Yeah, so wet gangrene.
All these are present in critical limb ischemia except breast pain, rubor, gangrene, skin ulcers.
In fact, the day that she said she didn't saw the child, she saw the father of the child brought,
We are getting some feedback.
Yeah. Okay. So 23. All these are present in critical limb ischemia except breast pain, rubor, gangrene, skin ulcers.
Okay, what are we going for?
Breast pain.
I'll go for rubor.
So the answer is rubor. I didn't mention critical limb ischemia, but when you do the ankle brachial index and usually less than 0.5, then you are dealing with a severe peripheral artery disease. And at that stage, we say the patient has critical limb ischemia. So for someone with very mild stage of the peripheral artery disease, they may not feel pain at rest. The only time they will feel pain is when they exert the muscles. So on exertion, that is when they will start feeling the pain. That's the intermittent claudication. But when it gets to the critical limb ischemia, even when you're at rest, you feel the pain. So the patient may present with rest pain. And because the occlusion is very severe, the patient can develop gangrene and they can develop skin ulcers at the affected area. So that is the classical signs of critical limb ischemia. You have skin ulcers, you have gangrene, and you have rest pain. Rubor is not part of the signs of critical limb ischemia.
Okay. 24. All these are true about ankle brachial index, except ABI of less than 0.9 suggests peripheral artery disease. Refers to the measurement of systolic and diastolic pressures of the ankle and arm. ABI of less than 0.5 suggests critical limb ischemia. ABI greater than 1.3 suggests non-compressible calcified vessels.
Refers to measurement of systolic and diastolic pressures.
So B. So you only use systolic pressures, not diastolic. So only systolic.
Okay. 25. Intermittent claudication in peripheral artery disease can be managed with all these except cilostazol, diosmin, naftidural oxalate, pentoxifylline.
So which of them?
B.
So except diosmin. Diosmin is using peripheral venous. The others peripheral artery.
So 26. All these are true about cilostazol except it's a phosphodiesterase inhibitor. Should be taken 30 minutes before meals or 30 minutes after meals. It's recommended to increase pain-free walking distance. Has antiplatelet activity.
B.
I thought we said it's 30 minutes before meals.
And 2 hours after.
Okay, so that's true. It's 30 minutes before or 2 hours after meals. Okay.
Match the following statements to the key below. Naftidural oxalate, cilostazol, diosmin, pentoxifylline. Contraindicated in heart failure.
Cilostazol.
Cilostazol.
Yeah, so cilostazol.
Can cause nephrolithiasis.
Dual oxalate.
Yeah, naftidural oxalate.
Indicated in varicose veins.
C.
Diosmin.
Yeah.
5.
See, that's
Hydroxy.
29, the answer.
29
So
was
29.
C.
Yeah, diosmin.
Thanks.
5 hydroxytryptamine 2 receptor antagonist.
Naftidural oxalate.
Yeah, so naftidural oxalate.
Use the key below to answer the following questions. First statement is true. Please,
Okay,
someone.
so that's the session.
What's the answer for 28?
28. Yeah. 28 was
Please, it's
A.
27B. And 29, please. 29 is D.
C.
29 is C.
C.
Yes.
27.
29 is C. Okay. And 28 is A.
Yeah.
Then, then please, then 30 is 30A.
Yes.
Thank you.
You understand why the answers are what they are?
Yes,
Seven
please.
is
You
B, right?
explained when you were teaching about the medication.
You said?
Yes, please. You explained them when you were talking about the pharmacological management for the PAD. You were talking about the three main medications.
Okay, that's good.
31. Supervised exercise therapy is recommended over unsupervised exercise therapy in PAD because exercise can worsen pain associated with intermittent claudication.
A.
Yeah, true related.
Yeah, so the answer is A.
Okay.
So they are related. You said supervised exercise is recommended because the exercise you are doing can also worsen the PAD. So there is some level of exercise you should do. So it's A.
Okay. 32. Empagliflozin should be avoided in PAD patients with diabetes because it has been shown to increase the risk of amputation.
False true.
So for so that's D, right?
Yeah, false true is D.
So false true.
A.
Okay, I'm also hearing A. Any other answer? Any other answer?
A.
Okay, so we said that the SGLT2 inhibitors have been associated with increased risk of amputation. Like we said that the one that is of note is canagliflozin because in terms of prevalence, it has the highest risk. So if the patient has an established severe peripheral artery disease and the patient is at risk of amputation, you should avoid. That is not to say you should avoid SGLT2 inhibitors when you have diabetes and you also have PAD. So it's not all patients you should avoid. But we are talking about severe PAD. Severe PAD is someone with ABI less than 0.5. So that's the critical limb ischemia develop gangrene, they are at risk of amputation. But if the patient has ABI of say 0.8, is even though are indicated to give SGLT2 inhibitors, you can actually give. So you don't avoid. And even the ones you avoid, you are thinking of avoiding is canagliflozin, not EMPA or DAPA, because they have a very low risk. So it's canagliflozin you avoid. So the first statement is false. You don't avoid in PAD patients with diabetes. It's those with severe PAD at risk of amputation. Then the second statement has been shown to increase the risk of amputation. That's true. So it's false true.
Mm-hmm. 33. Acamprosate can be used in smoking cessation programs in PAD patients because smoking is a major risk factor in the development of PAD.
False true.
False true.
What do we use a campus
Alcohol dependence.
Hey.
Yeah, so for patients with alcohol dependence, we use a composite. So that is not used for smoking cessation. So the first statement is false. And the second statement is true.
Okay. 34. Cilostazol should be taken 30 minutes before meals or 2 hours after meals because high-fat meals markedly increase the absorption and risk of toxicity.
Okay, so what are you going for?
It's true related. That's A.
So true related A, that's true.
Okay. 35. Pentoxifylline is more effective than cilostazol for intermittent claudication management because pentoxifylline is a rheologic modifier.
B.
False true. D.
False true.
Yeah, so that's false true. So D.
36. Peripheral
Hello,
artery
sorry.
disease.
Sorry, I didn't get 34.
34. 34 was
34
A.
was A.
Okay.
36. Peripheral artery disease can lead to limb amputation because above knee amputation is preferred over below knee amputation.
True, false.
So first statement true, second statement false. Okay, so that's right.
That's C.
So
Yes.
above knee amputation is preferred over below. So that's a false statement. It's rather below knee amputation. And this is because you want to preserve the knee. And the knee helps with wearing of prosthetics and also help with mobility. If they do above knee amputation, it's difficult to wear prosthetics. It's difficult to move around without a knee. So the knee is very important in terms of flexibility and movement. So because of that, we prefer to do above and below knee amputation instead of above knee amputation. Okay, I think that's the last question, right?
Yes, please.
Okay. So any other questions? If there are no other questions, that brings us to the end of peripheral vascular disease. Our next topic will be DVT and PE. So you can read on it. Any questions? All right. So if there are no questions, we'll end here.
Thank you.
Thank you.